All right. Well, welcome everyone. Thank you for joining today. This is Healthcare Experience Foundation, and this is our part one of two parts of exploring HCAHPS 2.0. Today's session, part one, is unveiling HCAHPS 2.0 and what you need to know. Today, the focus is Katie Owens is the president and co-founder of Healthcare Experience Foundation, and we're going to review with you some of the questions or insights that you had that you wanted to be addressed on the webinar today. Talk about the changes to HCAHPS survey, talk about some of the additions and eliminations, what the new survey will look like starting in 2025. And lastly, how to really create success and take these changes and make some positive impacts when the survey is ready to roll out. And again, part two, if you haven't already registered, it will be next week. There is a QR code that you can sign up. You can go to our website to sign up for part two, elevating patient care and experience by maximizing HCAHPS 2.0. So again, this will really allow you to take that next step now that you understand the changes that are happening to the survey, but how to prepare your team to be successful with these new items and domains. A little bit about our team. This is Healthcare Experience Foundation. And again, we're so pleased to have you here today. We all know that success reaches beyond simply improving HCAHPS scores and performance measures. Real success and transformation occurs when we improve the lives and the livelihoods of those that are receiving and delivering that care. And so at Healthcare Experience Foundation, our mission is to transform healthcare experience so that every person can receive and deliver the best care. So that's what we're here to do. That's what we're passionate about. I have been in the experience world for over 18 years, and of 12 of them, I have known and worked with Katie Owens, who again is our president and founder, and I couldn't be more pleased to partner with her in this work that we do. We work with organizations, again, across the country, helping to support and improve the experience, and we are pleased that you're here to share that with us today. Katie?
Thank you, Kim. Good afternoon. And for those of you on the West Coast, enjoy the tail end of your morning. I am so excited and honored to be with you today as we look at quite possibly the most substantive changes that Centers for Medicare and Medicaid Services are putting into place regarding the proposed HCAHPS 2.0 survey. I in so many ways remember being an experienced leader of a 7-hospital health system when HCAHPS, the original, came out, being pregnant with now nearly my 18-year-old child, running around to very different communities, very different hospital facilities, working to equip the leaders, staff, and physicians for this new national patient experience survey. And so I'm excited to share with you some of our early assessment of the survey and ways to help you maximize the runway between now and when this proposed survey will go live, which is in January of 2025. So one of our core commitments at Healthcare Experience Foundation is that we customize our learning events to your priorities and needs. And so as you recall, as you registered for our conversation today, many of you shared current strengths with your HCAHPS and patient experience programs, and we've summarized some of these for you here. We heard there's stronger relationships over the last 12 months, more of a focus on evidence-based programs. You're implementing standard work. Some of you are seeing heightened degrees of C-suite engagement. Many of you cited some specific domains that have improved, and you've sustained those improvements. And what we're seeing nationally is really getting back to basics with some of the fundamentals of bedside behaviors, and many of you cited those gains. When we look at the limitations, what are some of the things that you shared that you're struggling with that you want to make sure that we focus on? We saw a number of threads around teamwork, quite a few around both performance consistency and response rates. We can do a whole webinar on looking at response rates. You also shared concerns around how to maintain performance, especially, I know many of you are working to do so in really a tumultuous environment for retention and consistency of staff. stabilizing performance, communication between medical personnel and patients. Some of you cited the frustration of feeling stuck. So hopefully in our time together today, we're sharing with you a lens with which you can use HCAHPS 2.0 to regain some momentum. We know through our national research that patient experience has yet to achieve the performance of pre-pandemic levels. So our patients are feeling the inconsistency of care delivery, and I'll publish in our follow-up materials that research. So this is an opportunity to help our team members reconnect to the consistency of behaviors that we would want for our loved ones. So let's take a step back, and just for a quick baseline, the Hospital Consumer Assessment of Healthcare Providers and System Surveys, as we so affectionately have created our acronym HCAHPS, that survey was implemented in 2006. Public reporting began in 2008. So we are nearly 2 decades. Well, we're in 2 decades. We're 4 years shy of the 20th anniversary. So this is not a new program. There's over 4,000 participating hospitals. It is a CMS pay for performance program. And the goal in 2006 was to create an apples to apples comparison of organizations. And we can, debate the merits and the challenges. There are many on both sides. What we do know is that there are about 2.3 million human lives in our patients that are completing this survey of eligible patients, your adult medical, surgical, OB patients, all payer types. And our performance is based on top box, that always expectation. Some of those guiding principles that have transcended decision-making over the last 2 decades are to have that objective and meaningful comparisons on issues that are important to patients. And I think you're going to see in some of these proposed changes to the composites and to the items, CMS has continued their listening tour of what patients and their loved ones are saying are important to their discernment of the quality of the experience and the interactions that they encounter during hospitalization. A second guiding principle, public reporting incentives to encourage us to improve quality of care, and then enhanced accountability and transparency. And as we know, HCAHPS is kind of a minimum standard. Are some of the basics of courtesy and respect, perceptions of quality occurring in our observations? And how often as patients are we observing those basic interactions? And it's not to supersede or compete with loyalty. It's a foundational principle with which loyalty can build upon. We're at that intersection. We have that excellent experience. Loyalty measures really look at service excellence. They're a driver of growth, of patient perceptions of patient-centeredness. It fuels our economic performance with patient retention. And loyalty really looks at how do patients feel about the care that you delivered. So some of the summary changes. So we're going to look quickly at questionnaires, measures, composites, individual and global items. The current survey, you can see, has 23 core items, 10 publicly reported measures, 6 composites. We're all familiar with nurse and doctor communication, responsiveness, care transitions, discharge information. Cleanliness and quiet at night are the 2 individual items, and then the 2 global items. So the proposed HCAHPS 2.0, which has been in a comment period since May 3rd, and I think the final rule is going to be in August, has 1 fewer item, so 22 core items. They're going to make some minor changes to the demographic fields. There are 11 measures. And then there are some changes. There will now be 7 composites. You will now see 2 new composites: restfulness of hospital environment and care coordination. We will see the elimination of the care transitions domain, which has typically hovered about 50% top box since that went into place about 10 years ago. And then there will be 2 individual items. So cleanliness will maintain. There will be a new item, which we'll dive into in a moment, around information about symptoms. And then the 2 global items, best hospital overall, and then likelihood to recommend, will remain. So looking at the domains that will have no change. So again, as we're thinking about the next steps of rallying our teams to be prepared for HCAHPS 2.0, should all of these proposed changes go into effect, we'll see the same level of evaluation, those same behaviors that we are accustomed to with nurse, physician, medication communication, discharge information, and then the 2 global items. The hospital environment composite will be removed, as will care transitions. We're going to see some modest wording change to responsiveness of staff. We will be adding restfulness of hospital environment, care coordination, and information about symptoms. Now, some methodology notables. There are recognition of more modernized survey techniques that were in place when HCAHPS began. There are 3 new web-first modes. So you can now combine, and again, this is a great opportunity to partner with your experience measurement vendor, webmail, webmail phone, in terms of that cadence. The largely the original methodologies, mail only, phone only, or mixed mode, mail phone, will remain in place and available for use. We will have a longer period for patients to have the opportunity to complete their HCAHPS survey. That time period is going to extend from 42 to 49 days, so modest addition of time. IVR has been eliminated. That will no longer be an approved methodology for HCAHPS. Another big change is that proxy respondents will have the opportunity to complete their a survey on behalf of their loved one. So originally, only the patient who was in the hospital was eligible to complete this. And we know, given many circumstances, it helps to have a caregiver support us in our healthcare. And so proxy respondents will be allowed, and there is a maximum of 12 supplemental items allowed to append to the HCAHPS survey. So again, some fairly substantive changes in not only the questionnaire, and also affording us as organizations with more modernized approaches to give patients the opportunity to give us feedback about the consistency of their care received. So some wording changes for responsiveness. I know many of you cited that you are working on responsiveness, and you're not alone. And again, this is incredibly nuanced here. We're going to go from potentially during this hospital stay, after you press the call button, how often did you get help as soon as you wanted, to during this hospital stay, when you asked for help right away, how often did you get help as soon as you needed? And I'm sure there's going to be lots of thoughts around this question as it gets implemented in our organizations. From our perspective as coaches, that standard is still always going to be in the eyes of the beholder. Context is going to be driven by the urgency with which that patient needs help. And I think we all know, by the time we ask for help in the role of a patient, we wanted help 5 minutes ago. And so I think this is going to continue to be an opportunity for our focus. Now, we're also going to see the introduction of restfulness of hospital environment. So of this composite, one item will move over from HCAHPS 1.0. And there will be 2 new items. So during this hospital stay, again, that's always going to be the anchor. How often were you able to get the rest you needed? We will continue, how often was the area around your room quiet at night? And then a new item, did the doctors, nurses, and other staff help you to rest and recover? Within care coordination, we're seeing the emergence of new items that we have known from national key driver analyses that are incredibly important to our patients. How often were we felt informed and kept up to date about our care? How often did the doctors, nurses, and hospital staff work well to care for you? So we're going to see more team involvement in HCAHPS. And we know many of you have felt stuck that the HCAHPS survey really has technically by role typically mention the doctors and nurses. So we're seeing more inclusive language to really demonstrate that everyone who wears a badge in our organizations is mission critical. And did the doctors, nurses, or other hospital staff work with you or your family or caregiver in making plans for your care after you left the hospital? And we see this so often in our Cares Connect discharge phone calls, where patients feel like there are opportunities to strengthen upstream dialogue around preparing them to go home versus when they're home and trying to remember, our plan of care, our new medication regimen, our follow-up care instructions. And then information about symptoms will be a new item added to public reporting. Did we get enough information about what symptoms or health problems to watch for after you left the hospital? And so the time period will still begin as early as 48 hours after discharge for asking these questions. So there's a few important upcoming milestones. So for the remainder of the time period left of 2024, which feels like we're on roller skates, I don't know if anybody else feels that way, we are maintaining our measurement for the duration of the year through the 31st of December. Continuing with the survey, this is the one perfect opportunity to work with your measurement partner around deciding the methodology that works best for you. Our team is happy to talk with you about, based on your results, what might be a good starting point for you. This is also your precious runway to prepare your leader, staff, and clinicians for HCAHPS 2.0. Beginning 2025 on January 1st, based on the final decision in August, the new survey and methodology will begin. In 2026, Hospital Compare will begin to publish these new reported measures for January through December 2025 data. Federal calendar year 2028, we will begin pay for performance. This will be our first value-based purchasing period based on this new methodology and these new performance, these new behavioral measurements. So please submit your questions, your comments. We will do our best to address those during our time together, as well as a supplemental FAQ document. We've compiled a number of resources to support you. So creating momentum with the new HCAHPS survey. One of the things that we talk often about with the organizations that we have the privilege of partnering with is that a score is a score, and it's at the end of the day, what excites our team members, where our team members find value and their connection of purpose isn't chasing a number. It's committing and connecting to the behaviors that we would want if it were our loved ones receiving care. And so we would highly recommend and advise that as you are preparing your care teams for HCAHPS 2.0, that we really focus on the behaviors and on the consistency of the interactions that we know that we want to achieve for our patients and their loved ones. And so one of the resources that we have provided for you, and that we would recommend that you consider as you're planning, is to help your leaders and your frontline caregivers understand the new accountability measure. And so we have created for you, and let me see if I can share this on my screen here. This is a quick evaluation and exercise with all of the new proposed HCAHPS 2.0 questions. This is an incredible opportunity for leaders, staff, physicians, advanced practice providers to really have a firsthand perspective and immersion of how patients hold us accountable for the quality of their experience. How does HCAHPS connect with other loyalty or experience measurement questionnaires that you have? How does HCAHPS connect to what you're seeing with your reputation management online, your Google reviews? The questions that are on the survey, and then have your team members, based on HCAHPS 2.0, the behaviors that they want to continue to maintain and that they want to focus to improve. And then maximizing your runway. We've also included a project plan. This is something that we can send. What's the target message for to meet the audience where they're at in preparing for the new survey, the new methodology? What do we want to make sure from a cascade communication standpoint the right team members are aware of, so they feel comfortable and confident and coming out swinging in January? And we will follow up. I see some questions around 2025 to 2027. We will carry over value-based purchasing through the end of this year, and then we'll confirm the pay for participation period and follow up in the FAQs. That's a great question. We also want to make sure that we have programmatic resources to help you prepare for and beyond HCAHPS 2.0. We spend a lot of time with organizations around highly reliable behaviors. We have HCAHPS workshops, custom improvement roadmaps, our Healthcare Experience Academy courses, and our HCAHPS library, as well as our HCAHPS Experience Guidebook. And on behalf of our entire team, we want to invite you to stay connected with us. We are proud to have our Healthcare Experience Matters podcast in over 75 countries. We also invite you to like our LinkedIn page that contains a lot of best practices, our monthly newsletter, and then invite you to participate in our 2024 calendar of certificate programs. We have some exciting certificate programs coming up with inclusive leadership with DEI foundations, health equity in the patient experience. In June, we'll have relationship rounding, leading for healthcare experience excellence, physician leadership foundations to advance care and experience, and coming soon for pre-registration is HCAHPS 2.0.
Now let's head into part 2 of this 2-part discussion on HCAHPS 2.0.
Thank you everyone for joining us today. Welcome back from a long weekend. I hope everyone enjoyed the long Memorial Weekend holiday. And again, thank you for being here so much. As we continue to dive into explore the changes to the HCAHPS survey that CMS has said they're going to make some changes to for next year. So we are all about continuing and exploring HCAHPS 2.0 is what it will be called. So for those of you who joined us last week, we talked a little bit about the changes to the actual survey instrument, some of the questions, some of the things that you can expect next year as they roll it out. And this session is a continuation from last week, where we're going to explore not just the what changed, but how we can, next steps, what we do with those changes. So today we're going to focus a little bit about what you shared about yourself before you came, you did a survey and shared some of your strengths and challenges. We're going to talk about that a little bit. And then again, how to leverage the new survey and how to concentrate, refocus your, kind of reinvigorate your patient experience initiatives, how to maintain the focus on the initiatives that are not changing, and then to get your teams ready for the changes that are coming, those new domains, and how to be successful on those. So my name is Kim Bixler, and I'm the Vice President of Patient Engagement. Today leading us, and she did amazing. We got so much great feedback last week on how she presented the material. Katie Owens, who is our president and co-founder, will be sharing more about the agenda topics as we go in. For those of you who aren't aware, Healthcare Experience Foundation, we have been, Katie and I have both been doing this for decades, this work. I've been doing this for 18 years. I've known her for 12 of it. And 7 years ago, Healthcare Experience Foundation was created. We work with organizations all across the country, and you could kind of see as some people kind of tagged in where they were from, West Coast to the East Coast and everywhere in between. So again, thank you for joining and giving us the opportunity to share this learning with you. A little bit about ourselves as well. Not only do we do coaching and training, but we also have a great certificate program that we've developed kind of when we couldn't get on site, but we know that this is a great way to share cost-effective training and development to your teams. So you can see the certificate calendar that we have coming up. If you're interested, you can scan the QR code or that'll direct you to our website to learn more about it. And I shared that you gave us some feedback when you registered to share, what were your strengths, what were your challenges. And unlike healthcare, I'm going to focus on the weaknesses today, and we're going to end with the highs. So I think some of the challenges that you shared, we can all relate to what we're all struggling with. In healthcare, what we've heard across the country when we talk to organizations, there's really challenges with making priorities when there's labor shortages. So we heard a lot about that there's staffing challenges. You can, I'm not going to read the full list, but you can see that's kind of the theme about, staffing challenges, how to do rounding. There's time commitments, nursing communication scores, not being consistent. We'll talk a little bit about that today. How do we give education to our teams? How do we work on response rates, again, staffing and physician communication? So thank you for sharing, and just know you're not alone, because we heard this from everyone who participated on the call, and this is what we hear when we talk to organizations across the country. Some of the wins that you shared, and again, we want to always focus on those wins because we know these are challenging times, but some of the strengths that you shared that you are experiencing is really revitalizing that bedside shift report. We know that's a bed practice, so that is great that your teams have that as a priority and a strength. Someone mentioned that you were ranked #1 for a year on patient satisfaction. That is amazing, and congratulations. In patient performance gains that you've seen, which are amazing. You're building relationships, you're teaming with care management teams, and you have nursing engagement. So thank you for sharing some of the challenges, kind of just reaffirmated what we've heard from people across the country. And we would just want to celebrate your strengths and the wins that you shared. So thank you for that.
Thank you so much, Kim. And thank you, everybody, for those heartfelt comments and verbatims that you shared. That truly helps our team focus our time and energy. One of the things that we covered in part 1 of this 2-part series, and if anybody needs a copy of that, just a recording of the slides, just send us a note in the chat or in Q&A, and we'll follow up with you. HCAHPS was designed at its core to be a minimum standard for patient experience measurement. It was not designed as a tool to measure patient loyalty, brand loyalty. It was designed for the basic fundamentals of measurement and the consistency with which these behaviors are experienced by our patients and our loved ones. And so as we sort of recenter ourselves in the second part of the conversation around what do we do with this new survey, that should the comment period proceed as anticipated, should this survey be approved in August, come January 1st, our patients will have some new standards of accountability for us. And one of the most fundamental human exercises that we like to do is just wearing the name badge and asking your team members, if this is your loved one's name on this badge, whether it's Noah, Jackie, Carrie, or Roberto, what would you want for them to say about the care that they've received? Because so many times there's a disparity between how well we think we can perform on that always to never scale, and if it were our loved one, what we would want them to experience. And we never want that chasm. We never want that gap in time and space between the always expectation we want for our loved ones and the care that we are perceived as delivering. And so as we work to regain and re-energize our patient experience efforts and taking advantage of this revised survey tool, which is the most comprehensive changes that CMS has made since probably 2012 when the care transition measure was added. This is an opportunity to help our team members reconnect and be re-inspired and to eliminate potential frustration. So just for those of you that are new to this series, we want to spend just a quick moment recapping the summary changes. So again, this is all anticipated based on the proposed CMS HCAHPS 2.0. The composites that are not expected to have any change are nursing, physician, medication, communication. The discharge composite will remain the same. The verbiage for overall rating and likelihood to recommend will remain the same. The hospital environment composite will be eliminated. Quiet at night will move into restfulness. Cleanliness will remain. The care transitions composite will be eliminated. There's some mild wording changes to responsiveness of staff. And we will have two new composites, restfulness of the hospital environment, care coordination, and a single publicly reported item on information about symptoms. And some of these methodology notables, just to recap, CMS has added 3 new web-first modes. So this is in recognition that, I mean, gosh, if any of us, for those of us that were rolling out HCAHPS in 2006, web-based surveys weren't really a thing. I mean, we did online panels, but it wasn't a holistic opportunity for reliable measurement. And that has made a tectonic shift in the past 2 decades. So webmail, web phone, webmail phone are now approved come January 1st options. All existing methodologies are still available for use. So mail, which is the predominant method, phone only, which is producing the highest response rate in HCAHPS today, and the mixed mode methodology of mail and phone. Those will all remain available for use. The data collection period will be extended from 42 to 49 days. So we're going to have to wait a little bit longer for survey results to be completed or not. IVR has been eliminated as an option. Proxy respondents have been allowed. So let's say I'm helping my husband, who I'm the primary caregiver of, respond to this survey. That will now be allowed. And there will be a maximum of 12 supplemental items beyond the HCAHPS 2.0 questionnaire question set. So I know I covered that really quickly. We have a much more extensive part 1 webinar that we'll make sure that if anybody needs a copy of that, please let us know. So let's take a step back and look at how do we help our teams refocus and leverage momentum. I want to share with you, for those who listen to our let me rewind the tape here. Our Healthcare Experience Matters podcast, Jan Ganida, who's the Senior Vice President of Operations for PRC, and I have been doing a longitudinal analysis of patient experience measurement since the period prior to the pandemic. And every quarter we reanalyze how patients are perceiving their experience relative to HCAHPS, the most apples to apples comparison. And what we've learned in our latest review, and had the chance to present this research at the Barrel Institute Global Conference a few weeks ago, it was really last month. Our patient experience results have not returned to pre-pandemic performance levels. Our patient experience is still more volatile than in the decade prior to the pandemic. And the key drivers of patient experience, teamwork, safety, staff courtesy, and respect are enduring. And you'll see in the new care coordination measure or composite that's been added by CMS, CMS will now be asking a consistency of teamwork question. And I think that's in recognition that for nearly the majority of the hospitals that we have the opportunity to coach, the perceptions of teamwork is that #1 predictor of overall experience and loyalty. And so what this has illuminated for us is that patients are feeling the disruption that our operating teams and our care delivery teams have been experiencing. And so this is a tremendous opportunity to bounce forward in helping our teams. And we want to use the runway. We have a few months between here and there, and we know that this may shift before the final survey is published. One of the things that we provided to all attendees last week was a sample HCAHPS domain and question list. We'll also publish that to for all of you attending today if you didn't get one last week. This is an opportunity for our leaders, staff, physicians, and advanced practice providers to understand the new the behaviors that are going to continue to be measured and the new behavioral expectations that HCAHPS 2.0 will illuminate for us. So this is an exercise that we found to be highly effective, where our frontline team members take the survey, they share in a facilitated manner, and we have a facilitation guide, their impressions of the survey. They can share questions or concerns that they have, and we steer them towards the 1 to 3 behaviors that they want to focus on to improve performance. We also know that reliability and intentional repetition of messaging is absolutely critical for change management. And so we've included a best practice that our coaching team uses a lot for creating momentum. We have to cast the vision. We have to explain, what we want to accomplish. And if we don't know, how will anybody else know? We want to create more consistent experiences. We want to improve our patient experience. We want to decrease the times when patients experience usually or sometimes. What's important is that as a leadership team, and this really starts with the your board and your executive team, are consistent in the mantra. And why does this matter? It may seem obvious to you why we want our patients to be able to say that that our team always worked in a way that felt well coordinated, but it may not be to others. And then what's the result? What do we want success to look like? What is the outcome we are aiming for? What will a win look like? And we've included some sample language for you. Now, when we look at the composites and the items remaining, we wanted to include from our HCAHPS leadership development 6 ways to gain perspective. So when we think about, these are going to be the enduring items as well as the 3 new areas of focus. One of the first opportunities that we have is to really ensure that our teams truly understand our HCAHPS performance. What are our percent top box performance measures? How does that translate into a national ranking or a regional ranking or a subsidiary ranking? How do we perform relative to the division or the market in our health system? Which items or domains are improving or decreasing the most? What are our key drivers? So that staff are getting the reality of their feedback. When staff work in a vacuum of understanding performance, it's sort of equivalent to, our parents seeing our report card, but us as students don't understand how well we performed on the test, the exam, or the homework assignment. Immersing our team members, viewing the new items and domains, not from our perspective as caregivers, but from the patient and their loved one's experience, from their lens, and what blind spots might that illuminate. This is an early and important opportunity to engage your patient and family advisory councils to get their firsthand feedback on these new domains, composites and items. They've got such an investment in your organization's success, and this is an early opportunity to enlist their support. Look thematically at your voice of the patient comments, your voices, recordings, your reviews, relative to helping your teams understand the story behind the measurement. And then doing some experience mapping. Our team has a lot of resources for experience mapping we can share so that you can look at those key milestones in the flow of the inpatient experience, the flow from direct admit versus an ED admission, to look at those HCAHPS consistencies and vulnerabilities. And then doubling down on what we call at Healthcare Experience Foundation universal competencies and skill building. We've also included for a self-assessment an HCAHPS 2.0 measurement to action assessment. So this is an opportunity for you to assign on a 5-point scale, 5 being your highly consistent, 1 being more highly variable, your awareness, your leadership team, and then your staff and your physicians and providers. So how well or consistently does your team understand current HCAHPS items and verbatim feedback, feel informed about areas of improvement or decrease, understand and feel equipped to focus on the behaviors that the new composites and items represent, understand your patient experience and your HCAHPS connection to quality, safety, and health equity. We have a certificate program on health equity and the patient experience that really looks at that intersection. Our next one is coming up in the fall. How consistent do your team members feel engaged and a part of solutions to improve versus being told how to improve or being told just go fix it, just show patients we're more responsive versus development with how. How often do they get feedback on performance? It's positive, especially recognition. We just had an opportunity to work with a really great physician leadership team this morning. And one of the universal truths in this organization is that most oftentimes the physicians and APPs get feedback on the patient experience when something's gone wrong or something was less than ideal. And the reality is the majority of your patients give you always. And a small proportion of your patients give you usually, sometimes, or never, or, you know, definitely, or maybe not. And then how consistent do your teams, or yourself, your leaders, your staff, have opportunities for learning and growth to improve patient experience and quality together? Now, when you look at this list, I'd love for you in the chat to share, what do you see as your #1 opportunity for heightened consistency as you start to think about preparation for HCAHPS 2.0? And Molly, you bet, we'll get you a copy of this presentation. So what do you see as that #1 opportunity for consistency? And I'm going to keep moving, and then we'll double back as I'm keeping an eye on the chat. So when we look at these new composites and items, restfulness of hospital environment is going to include a consistency measure. How often were you able to get the rest you needed? And when we do relationship rounding, we hear a lot about, sometimes it's not just about the quiet at night, but just the patient feel that they have the protected space. And remember, CMS did a lot of research in what patients and their loved ones encounter as they propose these new domains and measures. Not new and continued is how often around your room is the area around your room quiet at night. And what do we know? A truth is it will never be as quiet as what that patient's primary point of reference is, which is their home environment. During this hospital stay, did the doctors, nurses, and other hospital staff help you to rest and recover? So we're looking for that next level of support. So we're dialing up our opportunities here. Within care coordination, how often were you felt informed and up to date about your care? How often did the doctors, nurses, and staff work well together to care for you? Which again, that comes back to one of those, that #1 key driver in our longitudinal research. And did the doctors, nurses, and staff work with you in making plans for your care after you left the hospital? So for all those times when we've been in those discharge planning conversations and that patient and their loved one nodded and said they understood, only to be really confused and concerned as they're administering their own plan of care or trying to reconcile gaps in their medications from maybe something they were prescribed before they were in the hospital and a new medicine that they received a new prescription for during their hospitalization. And then the new publicly reported item around information about symptoms. Did our teams give your family or caregiver enough information about what symptoms or health problems to watch out for? And so these are proposed new dimensions and items. And when we look at skill building opportunities, where do we see that the most highly leverageable, universal skills that in our client base are demonstrated to impact outcomes. It really comes down to these three big things. We have our CARES communication methodology. This is highly reliable patient communication. What we're building are skills that improve HCAHPS and patient loyalty, quality and safety, reduction in serious safety incidents, and improvements in health equity and inclusive care. And so what we're looking to accomplish is reducing the power dynamic where we have unequal power. So we begin interactions to project confidence and build patient and family confidence to participate in their care, use empathy-based skills to anticipate likely needs, emotional needs and priorities before we address the task of care delivery for safety and procedural needs. Engaging in respectful communication, knowing that when patients are stressed, and 96% of our patients are stressed, the majority of how patients are deciphering information is our tone of voice and body language. And how do we maximize our high velocity words? How do we engage in health literacy skills to engage patients and their loved ones in care and process by employing teach-back and ensure a lasting impression by saying thank you and ensuring that safe transition? Relationship rounds, which accelerate a leader's connection. We've spent over 1,000 hours observing senior leader, employee, physician, and patient and family rounding since the beginning of the pandemic. And what we've learned and is highly informed not only the skill of relationship rounding and also the application of digital rounding is that we've really stubbed our toe and become stuck in a pattern of task rounding and audit rounding versus missing the opportunity for authentic conversations. And that's what relationship rounding in the application is designed to do. And CARES discharge phone calls, which is demonstrated to improve HCAHPS by 10 to 20, 30 national percentile rankings, as well as reduce hospitals' readmissions by 20% in readmission penalties. To validate health status is improving, staying the same, or getting worse, to validate the plan of care, medication access and concerns, primary care follow-up, and service experience. And our partner organizations that have adopted this methodology and escalation follow-up are seeing dramatic improvements within 3 to 6 months with HCAHPS and readmission. We also know during this runway, we have opportunities to develop and engage our teams. And these are some excerpts from our HCAHPS Experience Guide and the 2.0 version that's in publication and just sort of waiting for that final CMS approval. Giving our teams the opportunity to view the patient's perspective, our perspective, respond to the survey as if a patient would, and then work at the intersection of cares at admission, during rounding, and at discharge, which are those high impact memory drivers with which patients form their impressions. And this is an example from one of our HCAHPS leadership and team development sessions, where team members were given the opportunity to be a part of action planning to improve restfulness of the hospital environment. And you can see this isn't being told to. It's not one-dimensional. You are going to welcome the patient and explain our goals. To staff members and physicians and providers are having the opportunity to contribute to their plan of care. And so as Kim and I walk you through opportunities to support you beyond today, we really want to invite questions. I know many of you have asked for information on the first session, which we are really happy to provide. Kim, let's walk through some other opportunities.
Absolutely. Well, again, thank you for joining us today, and we'll send a follow-up. I will have the slides and the recording that'll be sent to attendees, and I can add the webinar recording from the first session, HCAHPS 2.0. So we will absolutely send that. Other ways that we can help support you, Katie had that guide that we have available. You can go to our website, or you can reach out to us if you're interested in getting a copy, purchasing that. We do workshops, speaking events, on-site assessments where we can help develop a customized roadmap for your team. And we have an excellent academy, which is on-demand courses that focuses on all the best practices, has an HCAHPS quick guide. So we have that available as well. We have our certificate program that we referenced, and we know that rounding is a best practice for employee, physician, and patient. So we do have apps, train the trainer, and ways that we can support you. Some free ways that we have is our podcast. Our podcast is international. We have so many people that attend it. You can scan the QR code to find Healthcare Experience Matters podcast. Connect with us on LinkedIn, so you're always knowing kind of what's in the know, what's coming up. We'd love to share. And again, you have our QR code to find out more about our certificate program. So we'd love to hear your feedback. We are passionate about supporting improvement and helping you just really accelerate in delivering the best care possible to your teams and to your communities. So thank you again for joining us. And please reach out if you have any questions. And again, we'll send this recording and all the materials at a follow-up.